Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Joyce Lee MD MPH. Joyce is a professor at the University of Michigan. She's a pediatrician, a diabetes specialist, and a clinical and health services researcher. She's very interested in the notion that human-centered design and design thinking, combined with emerging technologies such as mobile technology, data visualization, and social media, can transform the research enterprise and the delivery of clinical care. Much of her work is focused on the confluence of these streams and the creation of learning health systems. You can find her online at drasdesigner.com. Welcome, Joyce, and thanks for joining us.
Thanks for having me.
It is a pleasure to speak with you always. And to kick things off here, I'd like to ask if you could give us your definition of design thinking.
I think design thinking it's simply a form of problem solving, but I think it's a form of problem solving that's participatory in nature. So if you're designing a health technology or a service or any sort of tool for health, I think it's important for the individual developing the solution to engage the stakeholders who are going to be using the product, right? So that could be patients and caregivers, that could be clinicians, and I really do believe that the best product or service or system will be designed when that design process is iterative and participatory.
Right. So rather than just deliver a finished product to an end user, users need to be involved in the design of the product if we expect people to actually use them, right?
Yeah, and I think that one of the lessons that I've gained in my evolution, right, in my learning about this whole approach to problem solving as a clinician is that it's a process that actually helps you answer whether you're asking the right question or solving the right problem in the first place. Right? Because I think we make a lot of assumptions about what user problems are and what user solutions could be, right? But what I've often found serendipitously by using the design thinking process is that the problems or issues that have been defined by the stakeholders, say patients and caregivers, they're nothing that I could have imagined or thought of as something that needed to be addressed. And that's why I think the empathy piece and the listening piece and just taking the time to engage that way is really important because I think there are a lot of assumptions made in the system.
Okay. So it sounds like we're talking about something way beyond UI or UX. We're talking about basic design, even deciding what it is that we want to design.
Yeah, and I can give you a small example that I think is meaningful, and it's taught me a lot. I mean, I wouldn't necessarily say that it's like changed healthcare delivery, but we have a collaborative called Health Design by Us. We're healthcare stakeholders, but as well individuals from art and design, information, technologists, designers, right? And we've held a bunch of workshops at the University of Michigan to engage, to expose, I think, patients, caregivers, students, and trainees, as well as staff and faculty, like around the process of design thinking, right? And so we had a workshop a couple of years ago where we had a teenager with type 1 diabetes who was participating as a client. And there was a group of us sort of sitting around a table going through that design thinking process to hear sort of what her articulated problems were and to see if we could sort of develop a quick set of solutions that might solve the problem that she articulated for us, right? And what was interesting is that, I'm an endocrinologist, so I'm a diabetes doctor, and so, I might say, she needs a logging app for her blood sugars, right? Because we know that teenagers don't have the best outcomes with regard to glucose control as other kids do in our population, right? But what was so fascinating to me about that process is that one of the things that she talked about was the fact that she was texting her mother back and forth during school to help with diabetes management and send blood sugars back and forth. But she said it created a lot of tension. Once having identified this problem, like the group came up with this idea called diabetes emoji or diabetes emoji, right? Where there would be sort of diabetes related emoji that she could use to sort of ease the tension in that communication with her parents during the day. And so we ended up developing some version of that. So it's available now on the sticker store for iMessage. But I think it's a good example of if you don't sit in the shoes of, or if you don't sort of see the world from where the patients and caregivers are, you could be asking the wrong question, which will automatically make a product that is not useful to the user.
Sure, if you're not even asking the right question. So do the questions that are best developed or answered through this process fall into particular categories? What you describe your example seems to cut across a number of different categories. So it's sort of a user experience kind of issue, but it's also much deeper than that.
Yeah, I mean, I think it gets to the emotional side, right, of diabetes, the difficulty of living with the chronic disease, right? And, the burden that it plays on relationships inside families, right? So again, like I think when you're a clinician running through clinic and you see, a patient every 15 minutes, like there's a very clinical aspect or way that we view how to manage diabetes. But I think the lived experience is so important. So if you don't bring that lived experience into the problem formulation, you're not going to address all the problems that need to be addressed when it comes to managing something as tough as type 1 diabetes.
Right. So you mentioned the clinical process. Is some of your work focused on the clinician as well as on the patient?
Yeah, I fully embrace design thinking. I think everyone should be trained in it, right? I think it's a fantastic way to solve problems, whether you're an educator or a clinician or a researcher. But I don't necessarily think that it's wholly embraced within the healthcare system. And in fact, I don't think many people sort of even think about what design is or even know what design is, right? So I've been working, I would say, at the systems level because I think, one of the things that's complicated about healthcare is that it's a complex system, right? And so you could design the best tool for the customer or the stakeholder, like the patient or caregiver, but it doesn't mean it's going to get adopted to the rest of the health system, right? Or that it's going to be used and disseminated, right? So one of the focuses that I've had as I've moved towards learning health systems is that you have to deal with multiple levels of systems design to create the best system for the collective of users or for the ecosystem. A very important piece of it is the patient-facing side and like what we can do and address for caregivers and patients. But, within the system, we also have clinicians, right? And we are using health information technology tools like Epic. That's one that we use at our system, right? They feel kind of like they were designed in the 90s and they're kind of hard to manage. But I think that, what I've been trying to do is sort of think about the entire system. So in addition to design, I've been bringing in interface elements of trying to improve the workflow as well as increase the structured documentation so we have more accurate data about outcomes for example, in the diabetes clinic, but as well also work on quality improvement. So sort of having a system to disseminate or affect change within the system, right? So that includes having metrics, but as well, I think change management, introduction of either evidence-based care, whether that's processes or other tools. I think all three of those things are tools or methods that I use to try and think about the optimally designed system for improving care.
So if I understand you correctly, you're talking about redesigning the clinician experience in Epic in connection with a certain set of types of patient encounters around diabetes management, or is it broader than that?
Yeah, I mean, we've started in diabetes management, and I want to fully recognize that the EHRs are not optimally designed, and there are a lot of issues with them, and there's probably a lot of better technology out there. But I think one of the things that I'm realizing as I'm learning the trade, and part of that has been actually becoming an Epic physician builder. So there's actually a whole training program that you can go through so that you can have sort of access to design some of your own tools for the clinic. I don't think that the care has been taken to really think about what users need at multiple levels, whether it's like the questionnaires that patients would be, kind of answering at the clinic on the tablets, right, all the way to, what are the sort of structured fields that we use as clinicians to be able to do our work and to measure outcomes. And so I feel like what ended up happening is we adopted technology and there was a lot of, let's build this, right? But the extent to which it was really thought out regarding how do you design the interface and the variables to make the system function optimally for everyone, that piece was really missing. And so I would definitely say that what I've been doing is trying to apply user-centered design towards even the clinician workflow for diabetes. And then we're now also moving towards obesity as well, because I do work in childhood obesity. So we're also very interested in trying to make it easier on the clinician, make it less burdensome for them to do the right thing with clinical decision support, as well as just standardized care and decreased variation across the board.
So to get very concrete for a minute, in terms of the work that you've done with the EHR customization, it sounds like there are now additional patient intake questionnaires or questionnaires to be used over time, individual clinician tools for different types of encounters or different types of patients? Is that what we're talking about?
Oh, absolutely. Definitely. And I mean, if you think about it, we've come a long way. Before we had EHRs, we couldn't even tell you how many patients we had. Like, we'd probably have to count like the number of paper charts in our clinic back room, right? So
Right.
I think having the technology has been really helpful. But even up till now, before we designed those questionnaires, I mean, we were having people fill out pieces of paper and then scanning them into the EHR as a PDF, right?
Right. So really
Which
not
seems
captured
crazy,
in a
right?
meaningful way.
Yeah, it's not captured in a meaningful way. It's not actionable. It's not allowing us to study and understand sort of issues that might be facing our patients at scale that we can try and solve with different forms of outreach. There's always this dream of healthcare being this awesome technology product, right? But in fact, what we have to do to a great extent is we don't have a lot more resources. We have to use the resources we have. So it's almost like we have to do a lot of cleaning the pipes in order to extract the value that we can out of the IT technology that we have. And again, like, I think it goes back to thinking about what we want to measure and why we want to measure it, and are those metrics meaningful? And I don't think that we sort of took the time to do that before we went live. Part of that is trying to integrate this into the clinician workflow so that we actually can do less clicking and less note writing, right, and spend more time with the patient. And then how do we leverage all of that data to develop more systems and greater outreach at scale so that we can do more population management instead of doing things one-off as a clinician. We should be thinking more systems, which I think is a shift from where we've been as a health system in general.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Joyce Lee, physician, designer, and researcher, joining us from the University of Michigan. Joyce, how far into this project are you? Do you have some learnings? Has there been enough time to get some feedback from the experience to either refine the workflow or find that there are certain interventions that are facilitated by the changes that are yielding better clinical results?
I think we're still in the early stages. Part of what we're doing is we're collaborating with a larger collaborative called Humanity Exchange, where we know that we need to learn from our population, but as well we need to learn from other centers, right? So they're all collecting similar types of outcomes, and we're trying to band together to figure out where there's excellence or where there's success so that we can learn and adopt. I'm hoping that we'll have more to report soon, but in terms of actual outcomes, I think we're still in the early process of building the system. I think one of the things that I've definitely learned as a designer, whether it's a designer who engages with stakeholders or a designer who thinks about the complex system of healthcare, is that it takes way longer than you think, right? And it's much harder.
Always, right.
Right. And it's much harder, right, than you thought it was going to be. Even just, silly little things like we went live with questionnaires and then didn't realize that the size of the buttons for a question are literally the size of the longest answer. So you couldn't even see one full question on an entire computer-sized tablet because of that formatting. And then people were hitting continue, and then that was exiting them out of the whole system, right? So I think one of the lessons I've learned with Health IT, and particularly Epic, is if it can go wrong, it will go wrong.
Yeah, so need to build in more time and more cycles, right?
Yeah, exactly. We're learning more about sort of the documentation tools like the flow sheets for the clinicians and how they're not saving from encounter to encounter. It has definitely been an investment in time and effort, but I think what our hope is that we can do this not just for one clinic, but for many patients across many clinics around the arenas of obesity and diabetes in particular. And I think the other thing is that, coming from the world of academia, we are pretty siloed. I'm a clinician seeing my patients. Our health systems are pretty siloed in the way they're designed, right? So there are clinicians who do clinic, right? There are individuals who do quality improvement, but that's almost like a separate bucket of individuals. And then there are researchers who are trying to do interesting and cutting edge research. And my background is in originally in research and health services research in particular, right? But I think that this whole model learning of health systems is really important because what it's teaching me is that you need to be able to create the system that will serve all three purposes virtuously, right? And so, we shouldn't be double data collecting for different purposes. We shouldn't be having a silo between research such that there's no ability to introduce evidence-based improvement into the clinic. We shouldn't be not doing the basic standardization of care using health IT tools to decrease variation and improve certain processes of care that we need to be delivering, right? And I think there's probably discovery on the clinical side around what are the things that we can discover in the course of clinical care that can inspire new research. I'm trying to develop the optimal systems design using participatory design, using health IT, and using quality improvement methods to create really a well-designed system for healthcare. And I don't think we're there yet. We're not even close yet, but I think that's what we're moving towards. And that's what I'm hoping to do to make greater impact at scale when we talk the next time.
So when you say learning health system, it sounds like you're really talking about this virtual cycle of communication between these traditional silos within academic medicine.
Yeah.
So is there resistance to that? Is the resistance institutional or just sort of inertia? Or do you see people as being threatened by these ideas in some way? Or do people generally who you're working with see this as useful and worthwhile, but there's perhaps some institutional inertia?
I'm a pediatrician, so I think that most people or every person that I work with wants to improve care for kids, right? But I do think that we are locked in these systems that are designed for what was a different type of medicine back then. So in our office, for example, right, or in our division, we have obvious certified diabetes educators and physicians, right? And then we have administrative assistants. I think we kind of live in a new world where we need a lot more skill sets among that team, right? Because we need a patient advisor advocate, and we have one that we work with who we compensate for her time because we think that's really important. But that's something that we do and we have chosen to do. That's not an option within the system yet. Or we need data specialists. We need people who can help us code SQL and pull actionable tables out of Clarity, which is the database, right? To be able to use the data and take action with it, right? We need quality improvement specialists, like people who know how to measure progress with interventions to improve evidence-based care, and then who also know how to be change agents within a system that is tired and kind of cranky, right? So I
have institutional support for doing this, it sounds like.
So I would say we have a little bit of institutional support, but I wouldn't say that it funds the amount of work that we're putting into it. I've always been creative in that I'm a researcher as well as a clinician. I do probably only do a couple clinics a month, right? So I am able to sort of dovetail a little bit my research and my LHS agenda, but I think that's where the systems need to change, right? And we are in 2018, and it has been probably 6 years since we started this EHR platform. So I feel like our health system is definitely moving more towards population management and sort of this new form of care. But I wouldn't necessarily say that the personnel and the structure of who we have hires for is ready to really support that. And so you would think that we'd already be into the 21st century, but we're definitely not there yet, right? Because there's no line for a designer, right? There's no line for a designer in the pediatric diabetes clinic, right? So we're hoping to, make change bottom up. I think there's definitely kind of individuals in the system that we've connected with that are interested and willing and excited about this. But I think, in terms of thinking about sustainability and hardwiring into the system, I think that's something that we're going to have to eventually confront once we've done some of this initial work. And I don't think we're different than many other health systems out there. I know that there's, obviously places like Kaiser or the Mayo Clinic who probably are much more forward-thinking in the way they use information tools and the way that they've done, probably population management for the last, 10 or 15 years, right? Because they adopted the tools earlier.
What I would say is that a lot of this is driven by reimbursement and the way people think about reimbursement. And even though we've all been talking about value-based reimbursement for quite a while now, that happens at the macro level. But at the micro level, everything is still fee-for-service one way or another in terms of departmental budgets, et cetera. So that hasn't trickled down in a meaningful way, except for a couple of the outliers, like the Kaisers of the world, where that's been sort of a way of life for a lot longer. So, I think it definitely takes time.
Yeah, I mean, the other thing I think that we grapple with is that we're not a freestanding pediatric children's hospital, right? So, we fight with the adults, right, for resources. And, the adults, they're a bigger burden, right? They cost more money. They make more money, right, off of their care, right? So I think to a certain extent, ambulatory care for pediatric chronic conditions is not at the top of everyone's list because we're part of this larger ecosystem. We're very interested in kind of extending this learning health system model for, all of child health, because I think that's the kind of system that would benefit all of us. And I think we're getting closer because we have the tools at the point of care to change physician behavior. I mean, the patient portal has its limitations and it's not perfect in any way, but there is a tool right now that we can use to reach out to our patients and caregivers. And then the data is becoming bigger and bigger, right? So, how do we actually take it and do something with it? So I think it's an exciting time, but I think it's also on us to show the value of this type of design system to be able to make sure that it can persist and continue into the future.
Sure, it is a challenge. I wonder, Joyce, if you could say a word about the maker movement in healthcare. I know that's something that you're involved with as well.
When you think about levels of design, I think it's interesting, right? Because you can run the spectrum, right? You can go all the way from professional design, which is I'm going to design for you, patient, because I know exactly what you need, right? So like human-centered design, which is more, let's talk to stakeholders like patients and caregivers, but let's use professional designers to come up with what we think is the right solution for them, right? I would say that's kind of the model of like an IDEO or an Accenture, right? Sort of companies that are doing this at large. Then there's like participatory design, right? Which is let's design together. I think, if you're talking about a health system, the health system is still driving it, but to the extent that you can think about kind of designing with your stakeholders, right? So they have more involvement in that process. That's part of the continuum. And then finally, there's the maker movement. And I just realized from a colleague of mine in HCI, there's actually this whole concept of what they call meta design. So it's essentially the assumption that you're designing a system where everyone is assumed to be a designer. And I think that's what is really compelling about the maker movement, is that I think that the more you infuse patient and caregiver involvement or stakeholder involvement in the design process, the more successful you will be with the outcome. And I think we've seen examples of this in Night Scout. So there was a dad, John Kostick, who had a 4-year-old with type 1 diabetes, and he hacked into his Dexcom continuous glucose monitor to get the blood sugars off of that system because there was no mobile solution at the time, although there is now, right? And he was able to see it on his watch and on his mobile phone and see it on his desktop, right? So he had remote access to his kids' data. Other dads and individuals in the type 1 diabetes community saw it and said, hey, I want that tool. He shared the code with them. And then they ended up opening up this Facebook group called CGM in the Cloud, which now has over 25,000 members and as well as, I think, 30 country groups across the globe. So it's essentially like a geek squad where people are sharing all sorts of resources, code, tools that they've used to develop their own mobile technology solutions for diabetes. And it's not just for monitoring. Now they've moved on to artificial pancreas solutions, which is really provocative and interesting and compelling, right? And I think what's fascinating about it.
It's a fantastic story, yes.
Yeah, and I think what's fascinating about it is that it was completely driven by the patients. It was solely developed by them. It was totally designed by them, right? And, I kind of call them like the computer homebrew club was for Steve Jobs right before he developed Apple Computer, right? But I kind of call them the diabetes homebrew club because they're developing all of the cutting edge technology for the next gen of diabetes care, right? Because they're just so smart and creative, but essentially they're individuals who understand a problem because they live it, they identify the problem, and then they just design it and solve it, right? So I kind of truly embrace the maker movement because I think it's, an example of how we should be redesigning diabetes care. It should not be about your doctor told you to change your doses, right? We know that the patients who are most successful with diabetes drive their own care. So I'm really interested in the model of the maker movement as a way to sort of really elevate patient expertise and achieve outcomes that we all want to achieve that we aren't necessarily achieving right now in our current healthcare delivery system.
Right, and tap into that level of engagement, really.
Yeah, absolutely. So we actually are fortunate to have funding from PCORI, the Patient-Centered Outcomes Research Institute, to do research engagement with teens with type 1 diabetes. So next semester, we're designing the curriculum now, but next semester we'll actually be training them to be research advisors, but we're using the model of the maker movement. They're going to be programming their own data into Arduinos on Adafruit wearables. But we think it's, an important model to impart to the youth with diabetes to really help them achieve what we think they can and are capable of achieving, but perhaps the system hasn't allowed them to discover that yet.
Very good. So my last question, Joyce, is if you were to wake up 5 years in the future, what is one thing in healthcare that you would hope or expect to be different?
I would love for, LHS or learning health systems to become sort of the prototype. But I think in addition, because I think there's the healthcare system, but my desire would be for the healthcare system to become more participatory in the way that it designs care, to engage more patients and caregivers, and to maybe imagine that, diabetes clinic should be a makerspace, right, as opposed to a clinic room with the doctor and a patient, right? Why isn't health more peer-to-peer? Why isn't health about iterative learning? Why isn't health about trying new things, failing, and then trying again, right? I think that's what design and the maker movement teach us. So to the extent that we can introduce that kind of culture into healthcare, that to me would be, utopia.
That sounds like a terrific vision for the future. Well, thank you again for joining us today, Joyce. I appreciate your taking the time.
Thank you, David. I'm honored to be here.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.